Good morning, friends. Today, what I am going to talk, you have to only trust me. I won't be able to convince you on the topic of electrical system of the heart, because the whole thing is covered so much that even at the autopsy, where I spent 1 year, where I cut hundreds of hearts, the coronaries, arteries, very easy. We would inject something and show the arteries, any blocks. But when it came to the nervous system and the electrical system, nothing can be seen. This is exactly like in your modern flats what you do. Moment you buy a flat and then you decorate it, you don't want the electrical wires to be seen. You hide them, cover them, and yet that electricity is so important in that flat. It may be a flat of 10 crores, but if there is no electricity, you can't see at night, you can't have air conditioner to cool you. Nothing can be done if there is no electricity. Yet it is there, but covered. Nobody can see it. So similarly, in the heart, there are electrical lines. But even with the best postmortem, I have attended a postmortem in Massachusetts General Hospital, Boston, which is the world famous hospital for doing postmortem. If you died of paralysis or of all the 4 limbs, they will open your whole nervous system, cut the whole thing, spinal cord, and put it on the wall to study. But electrical system of the heart, no. Yes, the arrhythmologist can put a catheter and show different waves like cardiograms. That's possible. Otherwise, you can't see it. It's not visible. But coronary arteries, at the postmortem I can inject the dye also, and I can see these big vessels supplying the heart. So, and the public also knows now coronary artery disease. But what the GPs should know is your strength of diagnosing the blood vessel disease, not of the big vessels, but the small. There are hundreds of small vessels in the heart. They can be diseased. The symptom will be same. Angina pectoris. Angina pectoris is an excellent diagnosis. If a prisoner, politician, middle age, maybe overweight, with some habits, smoking, drinking, etc., may not be yours. And if he complains that he gets this complaint which is like angina pectoris, it is very difficult to disprove it. And yet your diagnosis is solid. Angina pectoris means any discomfort or any pain in upper half of the trunk above the navel, here, commonest is here. If any discomfort you are getting on exertion, and when you stop, disappears, finished, diagnosis is over. There cannot be as easier diagnosis than angina pectoris. And then, even if you do the test, don't go back on your diagnosis. Even if stress test is negative, even if angiography is normal. So what? What about the small vessels? Small vessels. Yes, if you want to study small vessels, we have got a test now called a nuclear scan. So you do nuclear studies. But nuclear studies are there in how many hospitals in the whole of population of Bombay of 20 million? There are not more than 10 centers or even less than that doing nuclear studies. So what I was telling you is that electrical system cannot be photographed, cannot be seen like coronary arteries. But indirectly we get information by studying in electrocardiogram, ECG. So when you see an ECG and lubbed up, each heartbeat is lubbed up. This lubbed up is translated in the ECG at this one. This is 1 lubbed up, 2 lubbed up, 3 lubbed up. From here we study indirectly the electrical system, which of course is very important. I mean, people have not given importance to it because unfortunately the clinicians and the specialists are not conscious of it. In 1 year in the autopsy room, I saw hundreds of patients of heart attack dying. The final diagnosis was cardiac standstill, cardiac failure. I didn't see a single patient report with it's called as electrical death. So if they don't write and we don't see in the autopsy, you can't promote it. And therefore, indirect studying. You see, this is P, we say P, Q, R, S, and this is T. Now, this is QRS complex, we call it, you can call it only R if you want, but QRS complex you can use. This is P, and the small p in front of this shows you conduction in the atria. So atrial contraction, ventricular contraction. You are studying both. So if you don't see a P wave, then atrial contraction is not important. Atria are very thin. Ventricles are thick like this, and the pumping which is done by the blood is by ventricles, 2 ventricles, right and left. But atria, left and right, are CT passage of the blood. They only do. They don't contract. So that you can see small wave, but it should be present. Then only we know that yes, atria are contracting. See, the ECG paper has got, it's not a plain paper. It's not a plain paper. It has got lines. It has got lines, and vertical lines, horizontal lines. And each fifth line is very dense. Each fifth line is very dense. With the result, you get small squares and big squares. Small squares, big squares. Now, this is for the for learning. That if I want to tell you that a P wave, for example, is as tall as, let's say, 3 small squares. Or if I want to ask you, what is the rate of this patient, heart rate, pulse rate? If I can make you remember that the next beat should come between 3 to 5 big squares. Why? Because if 3 big squares, this pulse comes here, it's coming very fast, because 3 will mean 100, but normal pulse rate is 60 to 100. So moment this comes earlier at 3, we call it tachycardia, fast pulse. At the same time, 1, 2, 3, 4, 5, a moment it comes more than 5, it is less than 60 heart rate. That is bradycardia. That is very slow. So anything between 3 and 5, 3.5, 4, 4.5 is normal. You don't have to calculate. Anyhow, here is a normal pulse rate of this patient. Electricity is good, and it's regular. Regular means if I call this as a soldier, and if there are 20 soldiers standing here, the distance between 2 soldiers will be absolutely same, like in a military drills and all when they conduct. Absolutely same distance between the two. Moment the distance is not same, one soldier is here, one soldier is here, third is, it's a disease, wrong. We call it irregular rhythm. Very, very important, very important. Once you miss this irregular rhythm, you would have missed a gross heart disease. Only by seeing the rhythm. Are they equally placed? So soldiers are standing equally. That's all. So the resting ECG which you take normally of every person is only mainly for electrical system. It is not mainly for myocardial infarction. Myocardial infarction today we have got blood enzymes, troponins and all. The blood enzymes can rise before the ECG becomes positive. So today ECG has become a third class test for heart attack. Blood tests have become number one. 2D echography has become number two. But 2D echo, the GP can't have. For 2D echo, you have to go to the center. Therefore, ECG has to be kept. Quite often it can show you heart attack. But really speaking, we are doing resting ECG to diagnose abnormalities in the electrical system, which we call as arrhythmias. The word is arrhythmia. Some abnormality in the electrical system. For example, slow pulse rate, bradycardia, fast pulse rate, tachycardia. You can take a resting ECG, you can take an ECG of Holter, 24 hours attached to a small monitor. You can take a ECG for 1 week in cases of fainting, you don't know what is happening, 1 month. So, in my opinion, you please invest some money. It is not too much money. It's not. Today for 5,000-10,000 rupees you can get an ECG machine. What is 5,000-10,000 rupees? Today if you send your car for servicing, a good servicing, it costs about 10,000 rupees. Servicing of a car. And I am talking about buying a machine. Every GP, once he has put his board, doctors must have an ECG machine. Must. But I don't know, you got a fear. Today you see that my grandson was showing me his watch. That, Dada, look at my watch. Shall I show you my cardiogram? He is telling me. Yes, he pressed some button. I could see the cardiogram. Where have we reached? And if the GPs remain without an ECG machine, it's a shame. Wrong. I mean, you invest, when to buy a shop, you give a pagadi of lakhs of rupees, and here you don't want to spend what, 5,000-10,000 rupees? Wrong. Yes, you can buy old type of machines which are cheaper. You don't have to have a fast machine where you press the knob and the whole field ECG comes out in 1 second. It can take 2-3 minutes. Switch on the ECG. Now there are 12 leads in the ECG machine. L1, L2, L3. This is like different cameras seeing from it heart from a different angle. AVR, AVL, AVF. V1 to V6. There are 6 here, 3 here, 9, 3, 12. Really speaking, out of all this, especially if you want to see only electrical system, only these are enough. Finish. L1, L2, L3. You don't have to have this. Moment you take a cardiogram, take a picture with your mobile, send it to some cardiologist who is your friend or some other GP who is more confident. And in 1 minute he will ring up, this patient has got so and so, heart attack, this patient has got, finished. What I don't understand, what is your problem? You don't have to learn to read an ECG. The time has come with your mobiles and all. As I was telling you, to study the electrical system, these 3 leads are enough. But to study heart attack, you need extra 9 channels. This of course is useless, AVR, but AVL, AVF, V1 to V6. See, the L1 shows you the front portion of the heart, which is very important, big front portion. If you get a heart attack of the front portion of the heart, plenty of chances you are going to die, or those people who say 40%, 30% death rate. But if you have got a heart attack of the posterior side, which we call as inferior, then this is the lead to see. That means this is for heart attack. But when you are diagnosing a heart attack, the patient is having discomfort, pain, ghabarahat, difficulty in breathing, sweating like a pig, vomiting. In the next, out of 40%, in the next 2 hours, 20% chances he is going to die. It's not a joke to pronounce you got a heart attack. You need some confidence. So for confidence sake, this L3, when you see an attack, you want to confirm more, look at AVF. So AVF shows you back portion of the heart. It's a small attack. You can die, not you can't die. But it's on the whole, small heart attack. But if you have a front portion, this L1, now you want to be more sure. You're sure it's a heart attack? For the front portion, dangerous. You look at this way. If this also shows the same thing, still you are not very confident, then you look at these leads, V1 to V6, V1, V2, V3, V4, V5. If all of them show or some of them show, that patient has got heart attack of the front portion of the heart, which is dangerous. But when you are taking the ECG, and especially if you buy these old machines and all, once you reach L1, L2, L3, AVR, AVL, AVF, you have to change the knob. You have to change the knob. Like in an air conditioner, you change the knobs. But if you forget to change the knob after AVF, the whole ECG will be wrong. Why? Because the same pattern will be repeated in V1 to V6. I have been taking ECG classes, not required. I realized they're wrong, not required for the GP. But GP can always take a photograph and send it for interpretation. But I used to take, for 65 years, I have taken ECG classes. In the first 30 years, I used to take in the medical college, and that class is about 7.5 to 8 hours. So all night we used to sit, 300, 400 students, and start at 9 o'clock at night, finish in the morning. But when I shifted to Birla Hall, where I could teach at a time 1,500 students, we used to start in the morning at 7 o'clock. 7 o'clock and finish by 2:33 before the drama start. But believe me, I have come to the conclusion now that I had to stop the lectures and not because of Corona. But I think it is good. It is good that I switched over to, you don't have to know the whole ECG. Wrong. A GP. And what you should know is very little. That I am going to show you today. So when the electrical system fails, what are the complaints? Palpitations. The patient says there was a kick. The patient faints at rest. Fainting is extremely common complaint. If your vagus nerve is a very important nerve for the heart. If it is extra strong, good, very weak, bad, you can faint due to weak vagus. But fainting at rest, dangerous. Look for a heart. Heart does not mean heart attack. Yes, you can have a heart attack and faint, of course, yes. But without a heart attack, you can faint due to a electrical system. We call that arrhythmia, I told you. The word is arrhythmia, medical word. You can have difficulty in breathing. You can have a giddiness attack. which could be due to electrical system. And finally, you can have sudden death. Very important. Very important. You see, sudden death, here is a patient where a cardiogram shows that P, QRS, everything is okay. P, QRS, T, P, QRS, T. And then suddenly what happens? Suddenly what happens? Suddenly what happens is this, that instead of a cardiogram, this means heart, instead of contracting, like this. Death. This is death. This is death. And you can see how fast the death came suddenly. This patient was normal, absolutely normal. Suddenly something has happened, finished. Then this patient dies. All these years, 65 years, I have been telling the doctors, students, whenever you are facing an electrical system abnormality, remember me. Me means what? What is my name? O.P. Kapoor. O.P.K. Remember O.P.K. These three words, if you forget, your patient chances of dying due to electrical system. O stands for oxygen. So a pulse oximeter must be normal if you are treating such any patient. P stands for pH, acidosis, and the K stands for potassium. Potassium is very, very important. Like that, people know about sodium. So everybody goes on saying, don't take junk food. It has got sodium, salt, sodium, hypertension. These. But when you come to potassium, very good. So fruits, vegetables, fruit juices have got potassium. So all blood pressure patients will tell them take more potassium, less sodium. That does not mean that too much potassium you can live long, and nothing like that. When the patient gets a kidney failure, he dies due to more potassium, not less potassium. Anyhow, low potassium is very important, and there are some other drugs which can interfere with the patient's symptoms. So, when a patient gets arrhythmia and you want to help of a specialist, don't send them to a cardiologist. No, cardiologists are very good for heart attacks. But to diagnose these complicated cases, you need arrhythmologist. Now, even in Bombay, you've got about half a dozen good arrhythmologists, but only half a dozen. While cardiologists are hundreds. So, if you have a problem about electricity, do see that you are sent to an arrhythmologist. He is the electrician of the hearts. Try to remember, when I started my practice in 1960, my old cars and all that, there was any electrical problem, including horn and all that, lights. I used to go to my usual mechanic. He would repair it. But today, if I have a problem with electrical system, I go to electrician of the car electrician, and they charge heavily. It's a specialized thing. So similarly in the heart, these doctors have specialized in the electricity of the heart. Now, I was telling you that I'm going to show you only L1, L2, L3. Other leads are not important in electricity of the heart setting. Therefore, I had a heart attack. I was telling you that lead 1, lead 2, lead 3. Okay. Now, all you mainly concentrate on lead 2. Out of 3 leads, the best lead for studying electricity is lead 2. Now, here is the first first beat. Each heartbeat is seen in the cardiogram like this, which means it has got a P, it has got QRS complex, or R if you want to call it, and then T. T is recovery. Now, this is his soldier, This is this soldier's cardiogram. Now the next beat should be like this. It is not. It is not. Now see, this is again his normal beat comes. These again 2 beats come. That means these soldiers are some Indians or Chinese, and these soldiers are like Russian, American, tall, hefty, they standing like this. So these are his normal beats. These are some abnormal beats have come in. Abnormal soldiers have come in. We call them extrasystoles. Extrasystoles. Extra beats. And the patient will complain of what? Palpitation. And maybe kick. Lub dub lub dub lub. Lub dub lub dub lub dub lub dub lub dub lub dub. See, that extra patient can feel. And then he comes to you for that complaint. Suppose you take an ECG and you find this. Then this diagnosis is extrasystole, extra heartbeats. Patient is very frightened. Extra heartbeat means you can die anytime. Nothing to worry. Don't give any drugs for this disease. There are many drugs they prescribe. The drugs of electricity of the heart have got more side effects than many other drugs in the body. More side effects. Avoid giving any medicine. Find out how much does he drink, how much coffee does he drink. Coffee, it's strong coffee, and you see these American people, strong coffee, but 3 to 4 times a day, big mug. It has got very high caffeine. Tea has got, here in our India, though, every 8 to 10 cups of tea, nothing. But it has got very high caffeine. Tobacco is nicotine, gutka is nicotine. If you are taking this, forget about the treatment. Just stop this and they will disappear. Even if they don't disappear, a little bit persist, nothing to worry. They are not harmful. They will occur more in sedentary patients who don't do exercise, don't do walking. So when you tell them, start doing 1 hour walk per day, my heart is already weak, extra heartbeats, and you're telling me to walk? Yes, walking reduces this extra heartbeat. If you make this man do exercise test, you will find when the pulse rate becomes fast, this disappear. So the treatment is walking. If he starts doing regular walks, omits his alcohol, coffee, tea, tobacco, gutka and all that, finish. That's the treatment of this extra heartbeat. Then the next question comes, are you sure 100% that he has no underlying heart disease? We are not missing something. And it happened again with Ranbir Kapoor. Few years back, he was overweight, alcohol, had diabetes, hypertension, everything there, but very healthy. He went for a routine stress test in a suburb in Bombay, Bandra. And when this lady was doing the stress test, and he is very intelligent, these guys are very intelligent. He saw on the screen this thing appearing. Huh? He told, hey madam, what is this? What is it? So she said, oh, you got extra heartbeats. And stop. He told her, stop. Ring up Bobby Kapoor, my doctor, ring up Bobby Kapoor. Tell him this is happening. She rang me up. That Ranbir Kapoor is there, and I found a lot of extra systoles. Otherwise, cardiogram was normal, resting cardiogram was normal. So I told her, stop doing it. Send this patient for signal average ECG to arrhythmologist. Arrhythmologist was about 10 kilo away. He had to stop. He went to this arrhythmologist. He did signal average ECG, which was abnormal. Moment he said that, I said he has got coronary artery disease. Of course, he got shaken up immediately. I said some vessels are blocked. He flew to Delhi where he has got his own, Nandas have their own hospital. In 48 hours, bypass surgery was done. 3 vessels were blocked. And he is doing, this is a 10 years story. He is absolutely healthy and heart is very good. All I am saying is, in a patient where risk factors are there, you can ask for signal average ECG from a arrhythmologist. But in normal people, all young, healthy women, that sedentary life and working, sitting on the CG for 12 hours per day, all this is not required. You can assure them there is nothing wrong with the heart, you need more exercise and to stop all these things. This is the commonest disease of the electrical system you are going to see in your private practice. The next common disease is palpitation, and patient can feel the pulse rate fast. Doctor, I can hear my pulse, heart. That means fast pulse rate. Fast pulse rate. Now here if you see L2, look at the distance between the two R's. The distance between the two R's is hardly 2 big squares. 1, 2, 1. Now I told you, normally it should be more than 3 big squares because 3 is 100. Anything less than 3 is fast. Is less than 3. 1, 1.5, 2. And anything more than 5 big squares is instead of lub-dub, 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 lub-dub. So, moment you see that this man has got, we call it tachycardia, fast pulse, fast pulse. Look for P wave, or again lid 2 always, and you start, this must be P because this is QRS. P, QRS, P, QRS. P can be seen. And of course the QRS, the interval between the two limbs, hardly 1 small square. So normal width of QRS. P is seen, so this is called as sinus tachycardia is the name. Lot of patients will come to you in private practice. Doctor, humko dard hote. And you, so often the doctors say, kuch nahi hai. Your heart is very strong. No, find out the cause. For example, asthma drugs. I must have seen hundreds in the last 50, 60 years, hundreds of patients of asthma coming to you for palpitation. Doctor साहब, वो asthma है लेकिन अभी दूसरी हार्ट की बीमारी शुरू हो गई, दर्द होता है. They are all taking inhalers, and they are supposed to be steroid inhalers. But no, most of the steroid inhalers have also got bronchodilator, salbutamol. Salbutamol is notorious for causing dard. In some people it does not, in some people it causes. So if you diagnose that, all I will do is to prescribe him pure steroid and remove salbutamol. Finished. His complaint is gone. Blood pressure patient. You can give them alpha blockers, beta blockers, calcium blockers. There are so many drugs available for blood pressure patient. But if somebody is taking calcium blocker and he comes for this palpitation, then you will have to stop calcium blocker and change the drug to beta blocker. What difference it makes? Anything which will control his blood pressure. And when it comes to the next very important cause, thyrotoxicosis, more thyroid in the body, it causes fast pulse. This is not worth remembering. Not worth remembering. Why? When there is more thyroid in the body, the first symptom which occurs is rapid loss of weight. That patient will be worried. Within 1 month he has lost 4 to 6 kilo weight in spite of eating normal. In spite of eating normal food. That is the time you only feel his pulse rate. Feel his pulse rate. Moment it is fast, ECG shows sinus tachycardia. P is present. So that is increased thyroid in the body, disease which needs treatment. Diabetic patients. In the late stages, not early diabetic, late diabetic patient, after 10-15 years, they might develop autonomic nervous system where they develop postural hypotension. So giddiness on standing, because as soon as they stand, the blood pressure falls by 10-20 millimeter. Some of them will have diarrhea at night. Night diarrhea is not to be accepted as irritable colon. Sorry. Night diarrhea, you have to investigate the cause of it. which could be cancer, which could be ulcerative colitis, which could be Crohn's disease, but in a diabetic patient. So these are the causes. You treat the cause, finished. You have treated. Then there is fast palpitations of a disease which only you people will see as GPs. Specialists will not see it. I mean, it's very interesting that there is a cardiac emergency which only GP can see and can treat. And then you don't want to know it? You must know it. You must know it 100%. 100%. We call it SVT, supraventricular tachycardia. There are people who call it atrial tachycardia. That means starting with the atria, something wrong in the electricity of the atria. So what we find is palpitation and see the pulse rate, 2 big squares. 2 big square is 150. 300 divided by number of big squares. 150 is a very fast pulse. So therefore patient is upset. And with that fast palpitation, the patient can have giddiness, घबराहट, sense of as if he is going to die, dyspnea. Number of other symptoms because of this fast. And it occurs in whom? Normal people. So I always give an example of young women, young housewife, 20, 30 years old. No, how can she get a heart attack? But this sounds like a heart attack. That the woman was working, she was cooking, she went to bring water and suddenly started as if machine gun. You take the history properly, no? How did it start? So anything starting like that suddenly in a young lady who is otherwise not meant to get a heart attack is atrial tachycardia, supraventricular tachycardia. How do you diagnose it? Look at lead 2. This is a tachycardia. Okay. Now you look for P wave because sinus tachycardia is the commonest, which I showed you just now. So you start with R, S. Now T should be up, 2 waves up like that. It should be like that. Here there is nothing like that. Here R, S, down, up is complicated. You can't even know where is P, where is P. You can't, there is no P. There is no P separate than T. This is supraventricular tachycardia, atrial tachycardia. Every GP must know this. And the treatment is very easy, which can be done by a GP. I'll show you a small clipping of video from one of my classes, lectures on ECG. Tachycardia, RSTP, RSTP, P is separate, but suppose there is a, and in sinus tachycardia there is no abnormality in the heart. What is the abnormality in the heart? That short circuit. Short circuit is called as bypass tract. Well, in a atrial tachycardia, so what happens is, there is a fast pulse. See here, the rate is 140, 2, little more. Say 2 means 150. Now, with that tachycardia, you see the R, S, there is no S, but T, P, R, S, T, T. Where is the separate P and T? This goes there. That means the fused. There is no separate T. That there is tachycardia and that R, S, T, can't make out, R, S, T, there is no separate P. This is atrial tachycardia, also known as supraventricular tachycardia. And here, when those students used to be there, I used to give them, bless me. Some of this fellow come every now and then. So what do I bless? May God give you the first emergency in your practice of supraventricular tachycardia, atrial tachycardia. This is my blessing. Why? One case like that if you get, normally when you start your practice, you put Dr. J.R. Shah, this and that, and nobody comes. By mistake, some people will come because other doctor is not available. But if somebody comes, somebody is not available, tachycardia doctor is his doctor not available. You get the patient. And you find tachycardia. And you have got your ECG, the small dose ECG, and you take it. You find supraventricular tachycardia. Now you can show your and make a name. By the time that lady has come to you, it's a young girl of 22, 23. She came with somebody. By the time they come to you, another 5, 6 people come from that chawl. Kude geli? Manuti kide geli? Manisha kya? Manisha kude geli? Kude? Iti doctor. So that means crowd. Another 6, another 2, 8 people now. And this lady is saying, मला धडकन होतं, मला धडकन होतं, घाबरल्यासारखं वाटते, मरू जाणार, काय होऊन जाणार, काय करा लवकर. Her symptom is fast palpitation. So with palpitation, you get घबराहट, then you might feeling you might die, something might happen, and maybe slightly short of breath. You took an ECG, you found out is supraventricular tachycardia. Now the treatment is very simple. You tell her to put fingers in the mouth and at the back of the mouth and try to vomit. Produce that nausea. But not on the tongue, at the back. So actually like you want to vomit. So moment you do that, by doing that, suddenly the pulse rate becomes normal. Finished. There is a second method of reversible self-voice. That means you tell the patient to do this like you're passing stool. That stool is not coming out, hard, and then now you want to bring it out. So what you do? That is, so you tell that patient to do that. जैसे संडास में जोर लगा के ऐसा करता है ना, ऐसा जोर लगा. First we tell her sandas mein means then she has to close this here. Then start. Moment she does that, like that, the whole thing can stop. Dar. You treat it. Two simplest methods, they have to be explained to the patient. The next time you ever you do that. Don't stop there. They will not offer you money also. They will say, तुमने क्या किया क्या? कुछ नहीं किया. पैसा किस बात का? No, you have to be. That little bit manipulation. And so you bring the stethoscope and you have to examine the patient actually. And you examine the patient and make sure there is no thrill, no valvular heart disease, so you examine the patient. Now, when there is tachycardia, now suppose it is not responding to those, then you do what is called carotid massage. Carotid massage will be, that means you are auscultating. Carotid this is the carotid vessel. Sternomastoid, this is sternomastoid. See this muscle there. In front is carotid, the angle of the mandible. You put your thumb there. Once you put, say, left thumb will be easier because you are auscultating. So the sternum was right, you put your thumb. Patient is not responding to vomiting, there's nausea. So then you start massaging like this, like this. Normally also you must try. Any patient you just auscultate and do like that. You'll find the pulse rate becomes slow. Then lub dub lub dub lub dub lub dub lub dub lub. Normal. Here though, when you do that and you massage, go on massaging, lub dub lub dub lub dub lub dub lub dub, suddenly lub dub lub dub lub dub lub dub lub dub lub dub lub. It responded because this is the vagus main control, BST. You have hit there, and these attacks occur in young, healthy females, males, for no reason. No reason means they've got the short circuit by that tract. They've got a bypass tract in the heart from birth, but it has not given them trouble. This is the only trouble they get, an attack of supraventricular tachycardia, atrial tachycardia. And by doing this, you have brought it to sinus rhythm. Now, when this patient goes back to the chawl, what will she say? की मला धडकन झाला था, मी मेली, मला असं वाटत मी मरून जाणार, पण एक नवीन डॉक्टर आलाय, जी.आर. शाह म्हणून असं असं, काय ते जादू आहे, जादूगर, साईबाबा साईबाबा, गोळ्या नाही दिला, इंजेक्शन नाही दिला, खाली हातातून असं असं बरी झाली. How much impression you given? That without giving injection, without giving tablet, you only touched her here, you touched her something, became on. So terrific publicity. So this attack, as I said, if you do carotid massage, if the other thing don't work, the attack comes. Now after this, can she get more attacks? Yes, she can, but may not. It's very interesting. Although they have got this abnormality in the heart, which I call it as a bypass tract, if you send this patient now to any cardiologist, arrhythmologist, he will say, I'll burn this tract. He'll put a catheter in the heart, 3-4 lakhs rupees. Not necessary at all. Unless the attack was so severe that he fainted, patient fainted, or had difficulty in breathing, or it lasted for 24 hours, very long. Not worth. You can get that procedure instead of doing putting a stent in the heart. You're putting a radio frequency. You're burning that tract, which you can locate. People who can't afford, remember, people can't afford this young, so you can put them on a drug called verapamil. Verapamil can be given even as an injection during the attack and it controls the attack. But if the patient is afraid of more attacks, you can give oral verapamil. Verapamil is a drug for blood pressure. We give it to blood pressure patients. So give for 1 or 2 years for the blood pressure, and the patient has to be convinced that you have got no, actually she has got this from birth, but convince them you have got no heart attack, your heart is very good, lead a normal life. This is the treatment of atrial tachycardia. Patient comes with palpitation and you find fast pulse, pulse is again 2 squares, 150, and you find this wide, something wide. This is ventricular tachycardia. Ventricular tachycardia, in short, they call it VT. Moment you diagnose a VT in a hospital, in a ICU, in private, start shouting, take the patient to the nearest or ICU, where he can be given a shock. Because if you don't give shock, he will go into ventricular fibrillation, which I showed you earlier. Ventricular fibrillation is death. So these attacks occur mainly in patients who have got myocardial infarction. Ventricular tachycardia. So opposite of atrial tachycardia. Atrial tachycardia in young, healthy people, absolutely normal. Here, patient has got a heart attack. He is in the ICU. He was doing well. Suddenly, some nurse sees and she starts shouting, VT, VT, VT. Moment she starts shouting VT, the other nurses come, VT. All the nurses collect. They leave their own patient, other patient. They all collect. And doctor, call doctor for shock. Shock is given. Till he is given shock, he can die suddenly due to ventricular fibrillation. So what a contrast between the two. Fast pulse is tachycardia. I'll show you another clip of video where this is R wave is called as QRS, another name for R wave. That means it has got two limbs, upper and lower. This width, this, if it becomes like this, more than 2.5 small square, that's called a wide QRS. Wide QRS means ventricular tachycardia. Very dangerous, very dangerous. And in my ECG class, where I used to take for 7 hours, so 7 hours is a long time, it's whole night. Here it used to be 7 o'clock in the morning till 2:30 in the afternoon. 2 intervals. So you have to make them laugh, otherwise they'll go to sleep, students and all. So then I used to show that the QRS is this. See, this is my 2 legs, this is QRS. If I am a female and I'm putting on short frock, if you see the women who put on short frock, when they sit like this. That means the distance here is only this much. Some will sit little like that, but some will sit like that. With a short frock I am talking about. And when you sit like that, you can see the chaddi. You can see the underwear from. So vulgar. That's a vulgar method of sitting with a short frock. So this vulgarness is ventricular tachycardia. The QRS becomes wide. Normally QRS is this QRS, normal. Atrial tachycardia, same. Sinus tachycardia. But once it becomes like this, ventricular tachycardia, dangerous, gone. That patient needs, if he is in a very good ICU, he cannot die because they give a shock immediately. Moment you give a shock, it becomes sinus rhythm. Then we come to other electrical abnormalities, like instead of fast pulse, slow pulse. Slow pulse, when the pulse becomes, normally pulse should not go to less than 60. When I say 60, on the ECG I will see 2 soldiers where the distance between the two will be more than 5 big squares. 5 is 60. Now here it is 1, 2, 3, 4, 5, 6, 7. It crosses 5. It's slow. So the soldiers are standing very slow, distant, slow. In medical word we call it bradycardia. There can be no symptoms at all. That's the most important thing. The slow pulse produces no palpitation, no symptoms. Occasionally maybe somebody might say like fainting, somebody has drawn the attention. And the slow pulse is diagnostic, especially normal in athletics. Most of the athletics, good athletics, the pulse rate is about 40, 35, 40. Nothing to worry. Good. heart is strong. But our drugs in medicine which we use, the commonest cause, the fellow who is not an athletic, he must be taking beta blocker. No, beta blockers are used in left and right in our practice. Beta blockers for hypertension, beta blockers for other conditions. So beta blockers can cause bradycardia. Once you know beta blocker is the cause, no treatment required. Either reduce the dose slightly if you want. And then there is a third cause of a slow pulse, sick sinus syndrome. Here, in elderly people, the pulse, when normally the pulse starts in SA node, sino-auricular node, then AV node, atrioventricular node, then from there the bundle of his, a big cord of electric wires going, then left bundle, right bundle, dividing. Left is big, right is small. So in this people, the starting point, sinus, is something wrong with that area. And you have only bradycardia. But suppose the pulse rate is, see, now moment the pulse rate is slow, you can see P, Q, R, S, T. P, Q, see P, Q, R, S, T, R, P, Q. P can be seen in front of every soldier. But moment you can slow pulse rate, very slow pulse rate, is hardly 30. But P can be seen here maybe. There is no P here. Moment there is no P here, that's a complete heart block. The condition is called as complete heart block. There may be no symptoms at all, very important. And yet it's such a dangerous condition, it can cause attacks of stroke, sudden unconsciousness attacks. And during the attack, patient can die. Governor of Bombay, years back, 30, 40 years, Nawab Ali Jung, he had complete heart block. A very healthy man, no alcohol, no smoking, nothing. But he was told to put a pacemaker. Treatment is pacemaker. He said no. He was told, you can get these attacks, you can die. He said no. We explained to him that pacemaker is something outside, like stent is inside the heart. The pacemaker is a small supari-like thing here, under the skin here we put, here. And then you cannot die, you cannot get this attack. Nawab Ali Jung was going, and on the airport, Bombay airport, he had this attack and died. So just to tell you that you have to coax the patient. Yes, it will be pacemaker, will cost 3-4 lakhs, but then it will save a life. It will save a life. Even a temporary heart block occurring in the heart attack patient in the ICU calls for temporary pacing. That's a temporary pacing. They put a wire, moment slow pulse disappears, finish. You don't have to continue pacing. No, sick sinus, difficult to diagnose. The arrhythmologist has to do a number of tests. But if you diagnose a sick sinus syndrome, or even if you suspect it, and the patient is getting fainting attacks, old man, once, twice, thrice in 4, 5, 6 months. You see, fainting is not only important for dying, but when you faint, you can break your leg, you can get fracture, other injuries, head injury. So they have to be convinced that pacemaker is your. You tell them, suppose you had a cancer, it costs 4 lakhs rupees to remove cancer. You will not do? You will not do? Of course you will do. So here God has not given you cancer, you are old, but God has given you sick sinus syndrome, where the pulse rate goes very slow. You get an attack of unconsciousness where you can die during the attack. Then next thing is irregular rhythm. See, normally heart rate is lub dub lub dub lub dub lub dub lub dub lub dub lub dub, very regular, very regular. If you find hearing the heart rate, heartbeat, and you find lub dub lub lub dub lub dub lub dub 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 lub dub 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 dub, irregular. This is irregular, very bad, very bad. And the condition which causes this is called atrial fibrillation. Lead to, look at, are they regular? These are soldiers standing, okay? What is the distance here? So 2.5 square, 2.5 square, 2.5 square, 2.5 square, and what is this distance? Suddenly 5 square, then again 2.5 square. So irregular rhythm. See here also, big distance, small. Moment the rhythm is irregular, and now you look for QS, RST, there is no P wave. So atria are not contracting. There is no P wave. Rhythm is irregular. The diagnosis is atrial fibrillation. There was a time when I used to teach years back, 30, 40, 50 years back, where it's like any ordinary complication of the heart. Today, atrial fibrillation, I am telling you that my grandson, when he showed me his watch, and ECG started. ECG started, and what did I find? It was written down, diagnosis, normal rhythm, no evidence of atrial fibrillation. Why only atrial fibrillation? Why not all other electrical disturbances? Atrial fibrillation is a dirty complication in the heart, dirty disease. And most of these patients of atrial fibrillation, they come actually for stroke, hemiplegia. It is a neurologist who should become big-hearted. That patient comes for stroke, yes, agree. But that stroke can be due to a blood clot in the heart which has come up. So investigate the heart in this stroke patient. Instead of doing MRI of the brain and all, you do CT scan of the brain and do proper 2D echocardiography to see is there any blood clot which has travelled up. But normal 2D echocardiography, when you do, you can miss a small clot in the left atrium. So in this patient you must do transesophageal. That means put a 2D echo machine through the esophagus, because esophagus and atria are like this, touching each other. You get the most accurate finding. Smallest clot in the heart can be picked up there. And if that is so, then the treatment of that paralysis patient stroke is what? Anticoagulants. It is like every patient you do CT scan in paralysis. Why? To see is there any hemorrhage. If there is any hemorrhage, no anticoagulants, no aspirin. So similarly, if you see the patient has got atrial fibrillation, that patient will need permanent anticoagulants, lifetime, which is a terrific, dirty treatment. Now, in the other day I was telling you that even if a binge of alcohol you take, heavy alcohol in the weekend, you can develop atrial fibrillation. So, atrial fibrillation has got multiple causes, and when you read the literature, sometimes I get frightened. Like somebody writes that during the lifetime of a person, there are 25% chances he might develop atrial fibrillation sometime. I get frightened. I have not seen it so often like that. But there are doctors like, or cardiologists in Bombay, Dr. B.K. Goyal. How his name came up, that the frontier Gandhi in the Afghanistan, he had atrial fibrillation, cardiac failure. He was not responding. So they said send him to Bombay Hospital. Bombay Hospital, B.K. Goyal is the cardiologist. B.K. Goyal, very man with a lot of influence, and he managed to get from abroad intravenous amiodarone, and he gave him intravenous amiodarone. Within few minutes, the atrial fibrillation became normal, sinus rhythm. And the publicity which he got all over Afghanistan, all over Pakistan, everywhere, the Dr. B.K. Goel cured a heart patient who was in the ECG and the wards for weeks together. But all I want to tell you, from that time his name started shooting up. He died some time back, but he had made a very big name from intravenous amiodarone. Yes, you can give it and try, but remember that the amiodarone is one of the worst drugs, maximum side effects on the liver, on the thyroid. Many doctors used to give amiodarone lifetime. The important thing is that when the atria don't contract, then there is a stasis of blood. With the result, clot formation takes place. And these clots remain there, they go in the brain and cause stroke. So you have to give them anticoagulants, lifetime, which is a very bad situation. So we used to give warfarin lifetime, but warfarin in nuisance is what? The prothrombin time, 3 weekly you have to do, lifetime. Because it can change. It can change if you eat some vegetables, green vegetables, and the prothrombin time can change. So it's a big nuisance, there is no question for that. Now we have got in the market direct anticoagulants, where all this is not required. You take direct anticoagulant lifetime, but the cost of direct anticoagulants per month is 4,000 rupees. How many middle class people can afford to take 4,000 rupees drug lifetime for years together? Best thing is to involve an arrhythmiologist. He might be able to give amiodarone or some other electrical thing. So, what I wanted to tell you, that some time back I told you that any patient who comes, you remember OPK, because somebody suddenly died of atrial fibrillation, then this is the story of Jayaprakash Narayan. Jayaprakash Narayan was the only leader in India who did not hold the position in the cabinet, and yet he was very famous. People loved him. And Jayaprakash Narayan, he died of some cardiac problem, and he was admitted in Jaslok Hospital. He had also kidney problem. So in Jaslok Hospital, he was under the treatment of Dr. Ashwin Mehta, A.B. Mehta, and the kidney was being looked after by Dr. Mani. So it happened that when he was admitted, he had cardiac failure, bad. So it came in the paper, so people started collecting around Jaslok Hospital that he is serious. And then the reporters came, and it happened that he died. Died means Dr. Ashwin Mehta announced in the TV that Jayaprakash Narayan is dead. By the time there was a crowd of about 20,000 people outside Jaslok Hospital. And they started beating the chest, oh, Jayaprakash Narayan, mar gaya. When he died, Dr. Mani, nephrologist, came with a report. He had collected the blood for potassium. Moment he entered, he showed that there was no potassium, 0.5 was his potassium. So Dr. Mani took potassium and all that and pushed it in, that drip was going on. Pushed the whole thing. As soon as he pushed in, within a minute or so, within 5 minutes Jayaprakash was alive. Now Dr. Ashwin Mehta announced, Dr. Jayaprakash Narayan abhi zinda ho gaya. Mar gaya tha, abhi zinda ho gaya. Public was enjoying and shouting and giving blessings to Dr. A.B. Mehta कि उसने मुर्दे को जिंदा कर दिया, मुर्दे को जिंदा कर दिया. Since then, Dr. A.B. Mehta, name shot up. Today he is still more than 80 years old. Still he has got a large practice, very large practice. It started with potassium. So OPK in all these arrhythmias has to be remembered. And then of course you can give anticoagulants. And finally I will show you 1 or 2 ECGs. which are very easy to diagnose, which are very bad. One is this ECG. You see here, look at the width of QRS complex, wide. This patient has no symptoms. Most of them are diabetic, hypertensive, smokers, drunkards. And the ECG says no infarction, no this, no enlargement. And they are sent with this LBBB. What is the diagnosis? LBBB, left bundle branch block. It's one of the big bundles which is conducting the electricity. See, normally what is the QRS? Here is about 3 small squares. What is the QRS in normal here? Not even one. Not even one small square. So look at the difference between the two. That I showed you in ventricular tachycardia. Dangerous, no? Yeah. And this is also dangerous. This is also dangerous. If somebody has got LBBB, please get his coronary angiography done. As a GP, I am advising you. He must be having gross coronary artery disease. Although he has no symptoms. He has no symptoms. Take it from me. Don't lose these patients. And then one more little thing I want to tell you about this PR interval. What is PR interval? Here is a one beat, second soldier, third soldier. So P, Q, R, ST. But is a big Q and ST is elevated. We call it elevated. See how the ST goes up. Convexity, pulled up. So L3 has got this. This is myocardial infarction, inferior wall, heart attack. But if you see the PR interval, starts PR means P, these are, it's more than one big square. Moment the PR interval is more than one big square. See here also, P, beginning of P, beginning of more than one. That's called a first degree heart block. It's a heart block, first degree, not like complete heart block which I showed you earlier. Extremely common condition. But what is important as a GP you have to remember, these patients, don't give them beta blockers ever for hypertension, migraine, or the other conditions. Why? Because they are liable to get second degree and then complete heart block in the future. So, the last thing you have to remember is that all these arrhythmias which I have described to you, they occur in myocardial infarction. So a heart attack patient, he gets a heart attack, he gets pain, he gets this. By the time you reach, he is normal. He is normal. And he says, "Nahi, doctor, kyun hospital mein jaane ka hai? Kya?" Okay. What he doesn't understand is that in the next 48 hours, the 20% chances he is going to die. Die of what? Arrhythmias. So when we send this heart attack patient to ICU, idea is what? To look at the ECG all the time. Any ventricular tachycardia, any supraventricular tachycardia, any heart block. You have to make the relations understand that especially in the first 48 hours, the chances of sudden death due to arrhythmias, which you will miss at home, no? So they have to be, all infarction patients should be admitted as early as possible in the ICU, and of course all heart attack patients nowadays are discharged within 5 days. So this is the value of knowing electricity of the heart. Thank you. This is R wave is called as QRS, another name for RL. That means it has got two limbs, upper and lower. This width